Hi there back home for those who are attending online. Moges Wubie, Moges, maybe you can come into the screen for a bit. Um, Moges Wubie, our PhD student and colleague from Ethiopia, is joining us. Moges, we already start working together in a pilot project in Ethiopia on family-based approaches from 2016 onwards. And from that project, yeah, a second one was developed. And in that second one, and also based on the previous one, you made out your PhD trajectory from that. And what is specific about that PhD trajectory, if I may, is that you decided to stay in Ethiopia. And most people who do a PhD trajectory within Ethiopia go abroad with the brain drain that goes with it. So I think it is very worthwhile to mention that you decided to stay in Ethiopia, and then the pandemic hit us, more us than you in Ethiopia, because you told me you had other problems still to face, and like Ebola, to mention another very contagious disease. Um, but I won't mow any more of these things, and would like to give you the floor as our guest of the afternoon. Um, yeah, so please go ahead. You will give us some information and an overview of your project, and then we have a discussion, and people from at home or via YouTube, via the live stream, can also post their questions in the live stream, and Jane Struger will moderate those. Okay, the floor is yours, Martin.
Could I have the phone over there, please, so I can read the questions? That's my phone. Thank you very much.
Okay, thank you very much, Alice, and thank you very much for those of you attending my presentation. As Alice said, just I'm working in Ethiopia, one of the public health university, which is the Debre Marcos University. I'm doing my PhD on the project of the assessing the effectiveness of family-based the participation of people with leprosy, podoconiosis, and lymphatic filariasis, and their families in.
Louder, louder.
Yeah. Okay. Okay. So families in the Amhara region, as you see in the slide, these are the team members in different sectors here in the Netherlands as well as in Ethiopia. In Ethiopia, two organizations, here in the Netherlands, two organizations involved in this research project. Well, maybe it's not normal starting from the general thing, but the normal one is just starting from the introduction. But let me take you as a general information to go through my presentation. The introduction, I will present the objective, the methods, the current and the future tasks in order to accomplish my PhD, what results we have got, and finally I would acknowledge those involved bodies. Well, when we see leprosy, I hope most of you are just familiar with the leprosy. It's the bacterial disease. This individual was once upon a time, he was healthy, he had healthy hand, he was serving as a soldier for his country, for his surrounding, but after a while, because of these microbes, he became, I'm sorry, just his finger lost, his foot lost, his eye, his ear, his nose, all the things just lost because of this leprosy. But he has a family, as you see here. She's his sister, but also infected by leprosy. She is the daughter of this woman, and also she's a nurse. participate in our project, in the family-based approach project. What do we think about the goal of medicine and the level of prevention? The goal of medicine is one just to promote health, to preserve health, to restore health when it is impaired, and the other to minimize suffering and distress. This is the goal of the medicine. So the goals are embedded in the prevention. We can limit that loss of fingers, that consequences, if we implement the prevention effectively. I will come later. We have 3 levels of prevention: primary prevention, secondary prevention, and tertiary prevention. So the prevention is an action aimed at one, if possible, eradicating, then eliminating, if not possible, still minimizing the impact of disease and disability. Or if none of these are feasible, retarding the progress is one of the prevention. Retarding as it is just one of the prevention. So, as you see here, I don't know, it's part not.
Yes, I don't know why that is. That wasn't a problem before, and I'm not sure what I can do to fix that because I think it's down to the physical projector being in a different place.
Okay. Okay, good. The first one, leprosy. As I said, it's bacterial disease, infectious. The other, lymphatic filariasis, is parasitic, caused by Wuchereria bancrofti, Burgea mala, and Burgea timori, transmitted by vector mosquito. And the other, podoconiosis. This podoconiosis is non-filarial elephantiasis, just caused by pupils expose themselves for red clay soil if they are going in barefoot. So all this causes disability. These 3 diseases is neglected tropical disease. Yeah, so these have multiple effects on persons affected by this disease. The first one is the pain, the impairment, and the disability. This may lead pupils for stigma and discrimination on one hand, mental health problem, as well as just participation restriction. This is not only restricted for persons affected by this disease. The stigma, the discrimination, just pass to the families as well. So it compromises the family quality of life.
You're out of shot.
Okay. It compromises the family quality of life. Well, as I said, leprosy, lymphatic filariasis, and podoconiosis causes impairment and disability. This is the main cause of stigma and discrimination based on this author's finding. So one of the good chance, this impairment is easily preventable if we implement the prevention mechanisms. So relatively simple methods exist for self-management of the disability. However, methods are not taught to the patients. One problem. The other, if they know it, again, just practicing it is also another difficulty, another challenge. So a key issue in lifelong need to practice is very important. Unless otherwise, if they are implementing lifelong self-care management at one time, the severity becomes very high, the disability more severe and severe. So this difficulty sustained without regular encouragement and support. Once if they are disabled, they are not able, for example, if they use water for keeping their personal hygiene, especially in developing countries, water is not accessible. They are just fetching in far distance. These are disabled, are not able to fetch water from far distance, unless otherwise the family members supports them, anybody supports them, it's impossible to practicing the self-care. So a strategy shown to be successful is the formation of self-care group is very important. But for this, the two main problems that are self-care group strategy are limited long-term sustainability and problems in accessing such a group. We say self-care group is very important, but there is a limitation. There is a problem behind this. One, as you see here, long-term sustainability. The other also, problem in accessing such a group. So, formation of a group is not practical because many pupils may face challenges due to private matters, the financial, as well as the geographical barriers. The geographical barriers. So family-based support may be much feasible in order to sustain this disability management. But less attention is given for this the family-based approach. This is not only in developing countries, but also, especially in developing countries, less attention is given for family-based approach. Well, this rationally helps us to do research in our country, Ethiopia. Due to our culture, especially in the northern part, with respect, the wife washes her husband's foot. Similarly, the children practice for their family. This is due to respect. I don't know how do you see this in gender-wise, but in Ethiopia, especially in the northern part, is common. This is the one. The other rationale behind is that if people do not expose their problems outside the family, but prefer to keep matters in their house, if one individual person is with disability is not exposed to the external environment because of fear of stigma. So this is another good chance. If we implement the family-based approach, we come up with a good result. The other also, the government mainly focuses on the patient service and for the community. It's just not concerned more about the family. So this all give us a good chance in order to implement the family-based intervention in Ethiopia. Previously, as Ali said, we do an exploration of the family-based approaches aimed at prevention and sustainable self-management of disability due to leprosy, podoconiosis, and lymphatic filariasis within the family in Awi zone. With this project, we come up with a good result, the impact of leprosy, podoconiosis, and lymphatic filariasis on family quality of life, a qualitative study. On the other hand, also, there is an exploration of family quality of life study. Already published, 2 articles published on this. Because of this, we identified these problems. There is an awareness, lack of awareness for the persons with disability and their family. On the other hand, also, they don't know how they manage their disability. And also social and economic problems. So this needs intervention. This needs a solution just to alleviate their disability and improves the family quality of life. So the awareness creation, the disability management, and socio-economic intervention is very important and vital for improving the livelihood as a whole, the family quality of life of pupils affected and their families. So the intervention mainly focuses on 3 areas. The first on the community, on the family and persons affected by leprosy. So these three interventions, can we implement the awareness creation for the community, for the family, as well as for the patient? It's possible. We can do it. Can we again implement the disability management for the community, for the family, and for the persons affected by the disability? It's impossible to implement in the community. Rather, we can just do on the family and the persons affected by the disability. So psychosocial and economic empowerment. Economic empowerment in the community is very difficult, but we can do all the other things in the community, in the family, as well as in persons with the disability. This was our intervention, what we have done before. So a proof of concept is just published again. A proof of concept published again. We come up with a good result. But it's not possible to say this one is effective. Why? Because we don't have a comparator group. Just we do on the family and the persons with disability. Just in order to say effective, we should have a comparator group. So another question comes up. Previously, as I said, 3 articles published. What problems left unanswered? Left unanswered is the one, how effective is the family-based approach aimed at the prevention and sustainable self-management? This is a question. So for these questions, we need to have RCT design, randomized controlled design. In one group, there is an intervention. In the other group also, there is a control group. So our objective was to assess the effectiveness of a family-based intervention aimed at prevention and sustainable self-management of disabilities, impacting the quality of life, the mental well-being, the participation of people with leprosy, as well as the family members. So this was our objective for the second project. It has 3 phases. The first is the preparation phase, the second implementation phase, and the third one is the follow-up phase. We do rigorous procedures for the preparation phase. The first, as you see here, ethical clearance. If it is randomized controlled trial, getting ethical clearance is very critical. So we have got the ethical clearance. Again, we recruit human power, assist our research in different areas, and we employed just by examining them, then training given for the research assistants, how they collect, what is the objective of the study and the like. What does it mean that is how disability comes in, all the things just and the workshop just inform the local health authorities about the project. The other also study site selection. This research again done in East and West Gojam zone, previously in Awi zone, but now in East and West Gojam zone. At the beginning, we select Sri Worada, but after a while, just because of less number of grade 2 disability and related with leprosy, we expanded to 6 districts. So the other also RCT register in Pan-African Clinical Trial Register, and we have got this number. The study protocol again published in British Medical Journal. The measurement using in this study, we use 5 measurements plus qualitative guiding questions. The 5 skills or tools is 1, neurology, attitude and the practice question. The other, the family quality of life, especially we have different family quality of life scale or tool, but we prefer the beach center family quality of life which has 25 questions or items. SARI stigma scale, stigma assessment and reduction of impact, which is 21 questions, participation scale, and a patient health questionnaire, and the other qualitative guiding data. But previously, 3 of them is not validated in Ethiopian context. So we should validate in order to measure effectively what it looks like, the family quality of life, what it looks like, the stigma level, what it looks like, the participation scale, the participation of pupils. So we do the qualitative, the semantic, conceptual, item, operational, equivalence, content validity. On the other hand also, we do quantitative reliability and validity checkup. 302 samples, 50 repeated measure. We use statistical data software like Epidata, SPSS, and AMOS for the analysis of the result. So we have got a good result. So when we evaluate overall the family quality of life, the SARI and the participation scale is reliable and valid in measuring the family quality of life, measuring the stigma, and measuring the participation restrictions. So we come up with this, the Cronbach alpha, ICC, standard derailment, and smallest detectable change, the floor and the ceiling effect as well, the floor and the ceiling effect. So all of this just measures the reliability and validity. So we prepared a manuscript for this and submitted for GLOSS NTD. You can find the preprint online, this one. And you can see, especially we do this for B-Center family quality of life, for our intention, for our purpose. At the time being, we need this one. In fact, we need the others as well, the SARI and the participation scale. We will prepare the manuscript and publish it, that one. So the implementation phase, randomized control trial, cluster randomized control trial are just undergoing. Sample size is 840, 420 for the persons with disability, and 420 for the family members. We will do, we do the measure at 3 times. The first, the baseline, the status. Then after the end of the 5 months or 5 sessions, and finally after the 12 months. This has their own importance. I'll come later. But one group is intervention, the other group is the control group. So the control group gets information without family involvement, gets material for keeping their personal hygiene, and also measure the change time to time. Whereas the intervention, they get the health education, train how to manage the disability, the health education with the family members, again get material. Yeah, we do this month to month for 5 consecutive months. After that, we measure it. So the follow-up and evaluation, we use the qualitative approach and quantitative approach. For example, for the qualitative approach, they say something about what gets from the family-based intervention, what success stories they have, what benefits get from the family-based intervention. So we use that one, and the quantitative using that 5 scales: the CAP, the family quality of life, SARI, the patient health questionnaire, and the participation scale. So at the beginning, we will have the baseline data, end of intervention, in order to see the short time effect of the intervention. Then after 1 year, in order to see the impact and sustainability. sustainability. Well, what questions comes on our mind to do my PhD? As you see, this is a vast project, but for my PhD, what questions to be answered? The first, what are the enabling factors for the implementation of the family-based intervention? We have already done the exploration study. So we have identified the enabling factors in Ethiopian context to do the intervention. What is the role of the family in the implementation of family-based intervention? When I present just our research, our project in one workshop, somebody asked me, why you involve only one family member? Why you add another family member? That's a challenge, the accessibility. Unless otherwise, if we give all the family-based intervention for the whole family, has a great, is higher outcome than just involving one family members. So just qualitatively, we want to see this one. What is the role of the family in the implementation of the family-based intervention? Is the measurement scale valid in the disease-related disability in Ethiopian context? This also is very important. Unless otherwise we use a valid tool, we come up with the wrong conclusion. So just this also need an answer. In fact, we have done the cross-cultural validation. How much is the burden of any disease-related disability? Again, we will see on the family quality of life. We will see by taking the baseline data for my PhD. So an exploration of family quality of life in persons with leprosy, lymphatic filariasis, and podoconiosis related disability and their family members in Ethiopia. Already we have examined the family quality of life concept by qualitative case study. This is Zuna et al. Concept on the family quality of life. As you see here, this person affected by the disease, disabled. This is one unit of the family, and this is the other family unit. If in order to come up with a good result, everybody's performance is vital and important. If the family tries to do their own best, unless otherwise the persons with disability implement that one effectively, we should not come up with a good result. So just the involvement of family, what it looks like in the outcome of the family quality of life. The third one is the cross-cultural validation of the peace center, I already addressed. Assessment of family quality of life and association with the stigma, the participation and mental well-being of persons affected by leprosy and family members. We'll also just do based on the baseline data. Finally, the expected result for the target groups, it will improve their CAP. Unless otherwise, if they are not knowledgeable, they cannot solve things, solve their disability, solve the improvement of the family quality of life. It should be knowledgeable, should have a good attitude, and should have a good practice. On the other hand, the improvement in activity levels and social participation, mental well-being, CAP, if their CAP improves, their stigma levels decrease. So socio-economic development also happen. Then the concrete output deliverables, we will have published articles. These published articles is very important for policymakers, planners, and I also accomplished my PhD within this. Finally, just my acknowledgement goes to the Institution of Research Ethics Review Committee, the zones administrator, the ward administrator, the study participant, the research assistants, the funder, the Leprosy Research Initiative, the disability studies in the Netherlands, the other INAPAL, Ethiopia National Association of Persons Affected by Leprosy, and Debre Marcos University. Finally, I would like to say thank you all for your attention. So good. If you have a question, just I can entertain.
Okay, so for the questions, I propose we take a 5-minute recess so I can reorganize the room a little bit, and then we can take the questions. So if you would just bear with me, this goes for the people on the stream, 5-minute recess.
Okay. So maybe somebody wants to ask questions for clarification or to have more idea about what the whole project is on, because you were very fast about the project that already lasts for 5 years. So I can imagine that you probably have questions to ask for clarification or whatever you would like to ask. Yeah?
Yes, I was actually very interested in knowing how you found all those people.
840 people, yeah.
That's not nothing. So please enlighten us how you did that.
Yeah, just in developing countries, the more prevalent diseases is the communicable and less the non-communicable diseases. Our area, East and West Gojam zone, is more prevalent for leprosy, podoconiosis, especially. In case of podoconiosis, as I said, just people are walking in barefoot, so the silicates in the soil, in red clay soil, expose themselves for this one, and lower limbs swell and become impaired and disabled. So this is a minimal number because we took both leprosy affected and the other also the podoconiosis. By itself, podoconiosis is more prevalent in that area. Leprosy is more prevalent in that area.
As a follow-up question, because earlier on in your presentation you told us that people are a bit, they want to keep the disability inside the house because of the stigma.
Yeah.
So did you also encounter this during recruiting the people? Because I understand there are many people with these disabilities.
Yeah, yeah.
But did you also come across people who were unwilling to open the door for you as researchers?
Yeah, just because of the fear of stigma, they're just hiding that persons with disability in their house. Mm-hmm. Sometimes, previously, even burned with the fire, just because of the fear of stigma, just sending somewhere else, just in separate area and the like, previously. But nowadays, it's time to time, the situation improves, though they prefer to hide in their house. Not only for these cases, for the other cases as well. So, if persons with disability in their home, they are not prepared to just expose for the environment, because fear of stigma. It's not only for the persons affected by that disease, but also for themselves. For example, not get marriage, the healthy person within that family, because they assume it is transmittable, it's genetic and the like. Because of lack of awareness of people, they believe on that. So that just the problem forced them to hide the disabled person in their home.
Yeah. But as a researcher, did you encounter those problems as well?
No, just for the time being, they have visible impairment, visible disability. So when we go home to home, some of them already registered in the healthcare system by the health extension workers in different localities.
Yeah.
Yeah.
So, but maybe you can explain a little bit more, because that is, I think, the background of the question. Here in the Netherlands, when you want to find specific respondents or participants for your study, you showed as well that you have filled out all those ethical forms, and it was really something. Took a long time to do that. So you decided to work with research assistants that were already knowledgeable about not only the region but also with the health system, and some were also people affected, wasn't it? Or within the family. Like at one photo you showed a daughter, I believe.
Yeah.
A daughter of, and she is one of the very, what is it? So it is a kind of in between persons and key persons that you use for recruitment, didn't you? So maybe you can.
Just we use the health extension workers combined with research assistants to register all persons with disability in that area. In fact, we set a criteria for involving just those persons with disability in this study. One of the criteria is grade 2, grade 2 disability in case of leprosy, but in case of podoconiosis, stage 2 and above. It has 5 stages. The first stage is not that much. We come up with maybe a good result, but that the stage 2 and above is more severe and visible swelling. Because of that, just in order to come up with a good result, just we set a criteria at the beginning. So what then actually on the in the study area, the research assistants and the local area health extension workers find these persons with disability.
Yeah, and those persons are knowledgeable of the situation they have experienced themselves, so it may be for them easier to be approached by those people.
You know, just even we found that the lymphatic filariasis it causes one lower limb swelling, the upper limb swelling, the hydrocele or swelling of the scrotum, and the other also swelling of breast. Even they count those persons with swelling of the scrotum around 25 and the like during their registration time. Peoples are not want to expose this group of peoples, you see, but they count that one.
We have a question from the internet, from Bernadette. Thank you, Moges, for your interesting presentation. I have a question about the family members who participate. Did you select them and thus their type of relationship to the patient randomly? The reason I ask this, in my own research, qualitative family involvement in Dutch end-of-life care, I saw an overrepresentation of wives and daughters. I really had to search for men's perspectives.
Thank you very much for having this question. It's interesting. Just what we do, we give priority for them to select the family members from whom gets more help. This is the one. The other also, we have another criteria of age. Those under 15 is not just handle what we give the health education, we show how the disability management and the like. So we give priority for them to select who avail for a long period of time with them to give help, support for them. So just we give priority for themselves.
But I think a related question that Bernadette asked is, what is the majority of type of family members? Do you had a daughter in the picture you showed?
Yeah.
Are there also men recruited? So can you give us some information about the numbers?
Yeah.
You 40 family members. Are those predominantly women or also men involved?
Yeah, in fact, just the baseline data entry is just undergoing.
Yeah.
I don't have on my hand, but most of the time, if the husband ill, his wife or his son or his daughter come with him and take the interventions.
So the family members involved can be also sons
Yeah.
or men.
Yeah, yeah,
Yeah.
just most of them are they are old age parents, father and mother, persons with disability. Their son or their daughter also come together with them.
Both.
Yeah,
So
both,
both.
both.
Okay.
Yeah.
Okay, that's interesting. Mhm.
So what about the people that had leprosy? I don't know how you say this.
Yeah.
Were they like, how is the gender and age, and did you like, are they mostly women, mostly men? Is it 50%? What about the age? Is it like very old people? Is it?
Yeah, again, we have age restriction on our study. Why? Just we are involving adults above 18 for the persons with disability up to 80 years, and the family members 15 and above. Why we do 15 and above? In our country system, the education system, they complete their elementary and high school at the age of 18. So the chance of living with them is very less. So there may be who present with them is 15 and above, up to 18. So just in order to include that group of peoples, we lower the family age to 15 and above, whereas for the persons with disability, 18 up to 80. Just why do this? Just if we take, for example, a 90-year-old may not implement effectively because of the performance of persons with disability. We undermine the result of the family-based intervention. Because of considering that, we limit on this.
Can you say something about the prevalence of leprosy or podoconiosis or LF? Is it evenly spread across ages from 18 until 80?
Yeah.
Is that
majorly
yeah?
the late 30 up to 80.
There are more older people than
Yeah,
younger
more
people.
older
Okay.
people. Yeah.
Because leprosy disease, when you get it, you have it for the rest of your life. So when you are infected at 18, a number of people will be infected at a young age, but they can also be infected.
Manifestation observed in the late age. Yeah.
And is your sample representative for that?
Yeah.
Just asking. I ought to know, of course.
I got a question on the qualitative research. I didn't get it right. If you started with the quantitative analysis, did you already start with the qualitative research?
Previously, we have conducted the qualitative research, the impact.
Yeah.
The impact of leprosy, podoconiosis, and LF on family quality of life. On the other hand, we do an exploration of factors related with the improvement of the family quality of life, and the other just the proof of concept, or we implement the intervention and we saw the result. The result was good and nice, but in order to say effective, we need to have comparator group. Unless otherwise the control group comparing with the result of the intervention with the control group, we cannot say 100% it is effective. In order to say effective, we should compare with the usual care. This is a different approach, the different scenario, what we have on our hand. So in order to compare this with the usual care, we will see the difference. So during that time, we can say this is effective because by this percent, it improves the family quality of life than the usual care in the practice, we say.
So I get it wrong that if you combine qualitative and quantitative research. You are combining it.
Yeah.
You do.
Yeah.
And you already did the part of the qualitative.
Yeah.
Okay. I was wondering how the medicine language, like from the diseases, resonates with the language of the people they experiencing their own disease. Do you understand my question?
No.
If the language of the diseases, the medical languages, like the language of the words about the disease, resonates it with the experiences of the people you interviewed?
Yeah, just they believe the cause of this is not as the scientific truth tell us. The scientific truth it tells us the cause of leprosy is bacteria, the cause of LF is parasite, the cause of podoconiosis is soil. But they believe the cause of this may be the punishment from God. The sin is developed by the sin. Just stands on dead snake. It's magic and the like. They believe they have different perception on the cause. You see?
Yeah.
So just awareness creation is very important for this. They should know what is the cause, what to do for that. For example, if persons affected by leprosy may lose their finger, why this consequence happens? We should tell. They should know how, unless otherwise it's very difficult to implement this one. As I have told you, the methods or the approaches we use for the disability management is simple routines. For example, one individual with a large swelling of foot, how he believe you keep your personal hygiene, you massage, you wear shoes and the like, reduces your swelling. It's difficult to believe, but just understand this, implement this, then you see the outcome on yourself. When you say this one, on the other day, on the other session, they give their testimony because we have got improvement on this. People with podoconiosis, they suffer a lot with acute attack every time. But if they keep their personal hygiene, the first thing what improves is the reduces the acute attack. If the farmers laughing at that time as like malaria, it's not get time to release their oxes. They sick, fall down on the ground because of the acute attack. You see? So when we teach them how they can reduce this acute attack, if they implement it effectively, the first thing, it reduces the episode of the acute attack. Yeah. So unless otherwise we teach them, we taught them, it's very difficult. This is due to this one, the real cause. Bacteria or parasite, they don't believe on that. So they're finding treatment in different areas, in holy water, in magician, and everywhere. Especially for the podoconiosis cases, to the near past, even the awareness of healthcare workers is very less. That was a challenge.
Yeah.
But after 2011, Professor Gail Davy came up with the research of podoconiosis in Ethiopia. After that, just even the healthcare workers' awareness improves. Yeah. But previously, this is just maybe happens, they don't know the exact cause of that one, even for the healthcare workers. It's very difficult during that time. So the guard from the health institution get back the patients. There is no treatment for this case, they said previously. But nowadays, no one says this one. The health professionals' awareness increases due to, thanks to the researchers. The other also, people again, because of getting education, now better and better. Even their habit of wearing shoe with time to time increases. When you see the prevalence of this disease, previously, just the literature said that it was present in France, in different developed countries as well. But because of the wearing shoe practice, now it's not a problem here in developed countries. Rather still a problem in developing countries. Yeah.
Yeah, so even though they originally think it's like a punishment from God, for example, they are open to advice on, for example, wearing shoes, or so they are open to gain awareness.
Yeah. Just in Rwanda, the government designed a policy. No, everybody should have their own shoes, wear shoes. If this policy avail in our country, this is not a problem after a while. In fact, once the affected individual has their own disability, but the new uh, prevalence or occurrence of the disease may not be present because if they wear shoes.
Yeah. Sounds so simple. Wear shoes.
Yeah. It's curious. In the Netherlands, we think that walking barefoot is healthy.
Yeah.
Yeah. I'm not a scientist. I'm not a researcher. I work for an organization that does lobby and advocacy for people with disabilities, and I work for a project in 6 African countries, and one of the partners is the leprosy mission. And I was wondering, and the goals of the project is to improve the standard of life and quality of life, and food security and livelihood for people with disabilities, and to connect in a better way with local government. So how can we create organizations for people with disabilities, and how can they connect with local government? And I was thinking that the outcome of your research, and that takes about a year, I thought I understood. How do you connect that with local the local situation? Because I think the real value is how to spread the findings of your research. And, but I don't think that's a topic in your research, or do you, at the end, could you give advice in that?
Yeah, just this is important question. Unless otherwise we expand the knowledge throughout the country, it's impossible to do this research and put in a shelf. We should do research, then we should force the policy makers to use these findings. Fortunately, I was called up by the regional health bureau officials to present our research. They found it from the website, and they called upon me to present this one. I presented there for the policy makers what to do. On the other hand, just in order to improve the livelihood, in order to become productive, we should design different mechanisms. One mechanism is just in order to have associations. Within that associations, they contribute a small amount of money to get a loan from that, to secure land from the government, just by creating organization. Then maybe build a meal house. The other also may shop. It's not only work on farming, because these ones, they are disabled, or if they are exposed themselves for soil, their conditions become severe and severe. So they should see another mechanism to sustain their livelihood improvement. Maybe rearing of goat, sheep, hen, and the like. So one of our intervention shows the direction of establishing an association. Fortunately, we're lucky. We took majority of our participants from association, leprosy association. That's why the Ethiopian National Association of Leprosy involved within this research. So just what we have got, one example in our previous project, a 60-age woman just affected by leprosy. Her disability condition was severe. She has 4 children, but her husband just detaches with her because of her condition. But we get her with the project and advise her, just show how she do to improve from her the disability conditions. She became healthy and ploughing in her surrounding and planting potato. Then after a while, she asks the research assistant, let me give you potato. This is your product, she said. You see, if they are healthy, they become productive. Yeah. The other mechanism also, we should think of just benefits beyond what we expect. For example, if you give a stove, energy saver stove, it's critical and important. Why? Because they save energy, they save wood. They are gathering wood in far distance. So that's economical. The other also, if that stove is just surrounded, people are not exposed themselves for the fire. One of the bad things in leprosy, it affects the nerve. So they are not feeling that burn. But if surrounded stove prevents them from further disability. Yeah. So we should think which approach, which thing is very important to change the livelihood of the family as well.
Okay, so we have some questions from the realm of the internet once again. Bernadette asks, you mentioned that the intervention group will get psychosocial and economic support. Can you explain what this entails, and can this alone not already enhance the family quality of life?
Thank you very much again for this question. In psychosocial, just giving counseling for the patients, for the family, is very important, even if they know the cause. They develop their own what you call it confidence, just how to handle their disability. If they handle their disability, they become productive. So that is just important for just minimizing their mental problem, because if they get more severe disability they worry too much. If they become healthy, they relieve from their mental health status. The other also, when we encourage them to create an association, they have got friend, so interact with pupils, know the character of the disease. So if pupils are aware about that, maybe they get marriage and the like. So by that it solves the social problem as well. The other also, in economy wise, just if they are healthy, they become productive. Also, we support them, just giving the personal hygiene materials like shoes, bathing, soap, Vaseline, and the like. It's important economic support for this group of populations. So one, if they are healthy, they are productive, even they are not incurring their cost for the treatment. If they are healthy, they save their money. On the other hand also, just we give also some materials like energy saver stoves, issues and the like. By doing that, we can come up with this one.
Okay, so we have another question from Misigana Hidara. I don't know if I'm pronouncing that correctly. I certainly hope I am. Would you reflect on how your research result will be implemented and used? Also, how can it contribute to our health system policy?
Thank you very much. Yesterday we were in discussion with my promoter, Alice Chippers. After doing this research, we need to have a policy analysis. What gaps in the health system? We should show the gap. We should show the result. If we should show the result and we should show the gap, the government health system accepts this approach for the management, for the improvement of the family quality of life of this group of population. So we will do a policy analysis after accomplishing this project.
Okay, so since we have no further questions, I'm going to read some acknowledgements. Mitzi Waltz wishes to send you her regards. And from that, we have Misigana Hidara says, thanks for the presentation. Hope we can get the work and use in our project implementation.
Thank you very much.
And yeah, there are no more questions online, so.
Good.
Anyone else have questions here?
No, thank you.
Okay, so I think in that case, we could close out. I know the people on the internet can't see me, but I assure you I do in fact have a body and I'm physically here. So I want to thank everybody for their attendance online and physical attendance as well. If Moges, you'd like to say some closing words or have some remarks, feel free.
Yeah, I don't have, but just acknowledged all the concerned bodies, including you, the participants, both attending online and here in person. I thank you very much, all of you, for having your time for this presentation. Thank you.
Thank you.
Okay, and with that, everyone have a good day.
Thank you.
Thank you.
It's okay.